At first, I will give the clinic introduction, and then I will be handing the session to Dr. Parveen Kumar.
Yeah. Okay. Good.
Okay. So, with all your due permission, I'm starting with the live now.
Yeah.
Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Clarinet, serving as the allocate session assistant to ensure a seamless experience. Clarinet is India's most trusted and widely used digital platform, offering a multitude of enhancing services, especially for doctors. Clarinet is elected to be chosen as digital partner for this event organized by Indian Society of Anesthesiologists. So today's focus would be total knee replacement. Let's begin today's session, for which I would like to invite Dr. Parveen sir. Over to you, sir.
Praveen, mute to
Hear
Lamra.
you, Praveen.
Sir, you're on mute, sir.
Yeah, yeah. Good evening to thank you. Good evening to one and all. I'm Dr. Praveen Kumar, Secretary ISA Visakhapatnam City Branch. Let us start today's proceedings with the introductory remarks of President Visakhapatnam City Branch, Dr. Aparanji Madam, Professor Andhra Medical College.
Good evening, all. I am Dr. Aparanji, Professor of Anesthesia, ISA City Branch President, Visakhapatnam. To all the dignitaries, welcome to all the dignitaries. ISA City Branch Visakhapatnam is honored to have Dr. J. Balavenkata Subramanian, Senior Consultant, Ganga Hospital, Coimbatore, President ISA National, as guest speakers for today's webinar. We thank Dr. Balavenkata sir for accepting our invitation on behalf of Andhra Medical College, Visakhapatnam, and ISA City Branch, Visakhapatnam, for making us part of ISA anesthesia simulation workshops. We are doing a workshop on 25th May. Welcome you, sir. We welcome our national past ISA presidents, Dr. A.S. Kameshwarao sir and Dr. Kuchela Babu sir, and our present president of our state, Dr. Suriseti Srinivasarao sir, to moderate this session. We welcome you all, sir. Thank you for accepting our invitation on behalf of ISA City Branch, Visakhapatnam. We welcome you for today's webinar. Welcome to all the participants for today's webinar. Over to Dr. Praveen, our ISA Secretary, ISA City Branch, Visakhapatnam.
It gives me immense pleasure to welcome each one of you to this special online academic session organized by ISA Visakhapatnam City Branch. Today's session is a true honor for all of us, as we are joined by none other than Dr. J. Balavenkata Subramanian sir, President ISA National, Honorary Secretary, World Federation of Society of Anesthesiologists. Dr. J. Balavenkata Subramanian sir, a name that resonates with leadership, innovation, and unwavering dedication to our specialty. We are privileged to have him speak to us today on a topic of immense clinical relevance, total knee replacement surgeries, anesthetic considerations. We are also proud to have with us three of the most respected personalities in Indian anesthesiology as moderators: Dr. A.S. Kameshwarao sir, past President ISA National and past President Indian Society for Study of Pain; Dr. V. Kuchela Babu sir, past President ISA National and godfather of our city branch; Dr. Suriseti Srinivasarao sir, our very own President of ISA AP. On behalf of entire executive body of ISA Visakhapatnam City Branch, I extend a warm welcome to all the delegates who have joined us this evening from various parts of the country. With that, I once again welcome you all and hand over the proceedings to our moderators for the evening to start with the introduction of our privileged speaker. Thank you.
Good evening, sir. I am Dr. Kuchela Babu. It is a very privilege and honor to introduce Dr. Balavenkat Subramaniam, MDDA, a senior consultant and academic director and Department of Anesthesia and Perioperative Care, Ganga Medical Center Hospital Private Limited, and Secretary of World Federation of Society of Anesthesiology 2024 to 26, and President at the Indian Society of Anesthesiology 2024 to 25. Immediate past President, Ocean Society of Regional Anesthesia, and Educational Committee member, World Federation of Society of Anesthesiology 2020 to 26, and National Chairman of Academic of Regional Anesthesia of India, a member of Astrapam Newsletter Committee Course Director. He has a lot of publications, especially is one of the pioneer in India, regional anesthesia workshops and regional anesthesia promotion throughout more than 20 years to make the people awareness of doing a regional blocks, and other so much of academic work done by Dr. Balavenkat. He has a WFSA Ganga Hospital Anesthesia Fellowship, and so many awards he have it. I hope the people, the delegates who are joined this webinar will be enriched his knowledge, not only the theoretically, has a practically done more than 20 years, a lot of knee replacement. I think we'll hear from his voice what is the best practice of knee replacement, uh, pre-operative and intraoperative and post-operative management, the most important patient of this knee replacement. I welcome Dr. Balavenkata Subramanian to present his presentation.
Thank you so much, sir. Can I share my screen?
Yes, sir.
Praveen, who is going to
Yes.
share? Yeah, share to.
Sir, you can see my screen, sir.
We are seeing your screen,
Yes,
sir.
sir.
My audio is clear?
Yeah, very good.
Okay. Respected moderators for this important session conducted by ISA Visakhapatnam City Branch with the help and jointly with Andhra Medical College. It's immense pleasure that this session is moderated by the Doyens of Anesthesia of India and ISA leaders, Dr. Kuchela Babusa, the past president of Indian Society of Anesthesiologists, Dr. Kameshwar Rao sir, past president of Indian Society of Anesthesiologists, and the current president of Andhra Pradesh state chapter of Indian Society of Anesthesiologists, Dr. Srinivas Rao, and President of ISA Visakhapatnam branch, Dr. Aparanji Madam, Secretary, Dr. Praveen Kumar Moturi, Treasurer, Dr. Shrikant, and the Academic Chair, Dr. Achekar, and all the Governing Council members of the state of ISA Andhra State and City Branch of ISA Visakhapatnam, and all the young postgraduates and all the delegates who are attending this session. I consider it as a privilege to be a part of this teaching program, and I congratulate ISA Visakhapatnam for doing this every month to enhance the knowledge and skill sets on certain important clinical cases which are essential for modern anesthesia practice. I bring to you greetings from the city of Coimbatore, which is adorned by the largest human bust on earth at the Isha Yoga Center called Adiyogi. Yoga in life would possibly prevent degeneration of various tissues of the body, including the joints. In fact, all those who possibly do yoga probably will develop osteoarthritis very late, and also they will have their muscles pretty strong that the chances of the degeneration will become very less. I bring to you greetings on behalf of the entire Governing Council of Indian Society of Anesthesiologists. And I'm very happy to share that Indian Society of Anesthesiologists has become the fourth largest branch in the whole world in terms of the World Federation of Society of Anesthesiologists. So among the 150 member societies who are members of the World Federation, India is on the fourth position after American Society, Chinese Society, German Society. The fourth one is the Indian Society of Anesthesiologists. And I would wanted to thank the entire team of leadership of past presidents for guiding this national body to what it has reached today. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore, a 650-bedded tertiary care referral center for orthopedics, trauma, major spine surgery, joint replacement surgery, and reconstructive microvascular surgery. And I'm also happy to share that this institution is also accredited by the National Board of Examinations to undergo DNB in anesthesia, and also the postdoctoral fellowship in nerve block and pain management affiliated to Dr. MGR Medical University. We run also the World Federation of Society of Anesthesiologists international fellowships in regional anesthesia. Also, we run the Asian Oceanic Society of Regional Anesthesia and Pain Medicine International Fellowship. And we have so far trained over 40 students from 18 countries who have undergone the 6 months training with us. We also run fellowship programs post MD, and currently it is all open for all those postgraduates who are interested in nerve blocks and to become perioperative physicians. They can visit our website www.gangahospital.com. Currently, the online applications are open, and it will be a virtual examination and followed by a screening and selection. So the course will start from January. So those one session will start in January, the other session will start in July. So those who are completing their course this December and those who are completing the course in the May next year, all are eligible to write this exam. So those who are completing in December can opt for the January session. Those who are completing their MD anesthesia in the month of May can take the July session. And this is an introduction about the institution. And as a joint replacement center, I'm very happy to share that, as Dr. Kuchela Babu sir said, we do close to 3,000 knees every year. And we are the second largest knee replacement institution in this country. And today I'm going to share several small insights and inputs which we have gathered over several years in this journey of learning about total knee replacement. Since a lot of postgraduates will be attending this session, I just wanted to start with a very important slide which has motivated me throughout my career. And this is from the thinker Mahatria Ra. He said, "We may be born in a middle-class family, but we can scale such heights in this lifetime that we can cause a revolution. We may be born to illiterate parents, but we can die as a scholar of world repute. We have been considered a misfit during our childhood days, but we can become role models for the future generation. What we are and what we have been has no bearing on what we can be. We can be what we choose to be." So for all the anesthesiologists who are attending this session, I want each one of you to aim very high. I wanted each one of you to achieve excellence in your professional life. And for doing that, you need to start working every single day as a postgraduate, both in terms of acquiring the clinical skill and also enhancing your knowledge by updating yourself. So you should have dedicated reading time every day, and you shouldn't think passing the exam is the reason why you have to study. But the real exam in life is knowledge. The knowledge that you accumulate as a postgraduate is such a powerful tool that you will be respected throughout your life for the knowledge you emanate. So I want each one of you to dedicate at least 2 hours every day, completely focused, and you need to read all that you do clinically on that particular day. If a new drug comes, you need to read everything about the new drug. If the patient vomited once, you need to read everything about what is the cause of perioperative nausea and vomiting. What are the centers which mediate? If there are 4 centers mediating it, what are the 4 drugs that can be used to mitigate vomiting? So you need to kind of go into the nitty-gritties of clinical care, and this should be bolstered by your phenomenal knowledge that you accumulate. So I would request each one of you to have dedicated time of reading every day to make sure that you are one of the most knowledgeable postgraduate who uh, come out of Andhra Medical College and from several institutions who are attending this session from the state of Andhra Pradesh. And it's very important, if you need to grow like this, you should make sure that you invest your time appropriately. So for everything that we want to do, we need time. In essence, we reach a point in life that time almost becomes our God. Those who know how to use their time diligently are those who are very, very successful. I wanted to quote India as a progressive country which has showed phenomenal consistent growth in the last 75 years plus post-independence. And I wanted this to be the inspiration for each one of us to become better. For example, these are the pictures about India when it got independence. This is how people traveled in 1947 when we got independence. But where are we now? It has been a phenomenal journey, and now India boasts the second largest highway network in the world. It boasts the largest sea link in the world. It is extremely modern, and the Indian Space Research Organization has done this country tremendous proud. We are the forefront of artificial intelligence and robotics, and this is all part of India. Several downtowns in India looks like this, including some of the big cities in this country, which looks like one of those developed nations, but this is a true picture of a downtown of an Indian city. And we went on to put Chandrayaan on the moon, showing that we have become extremely scientific, powerful in this whole world. All this happened. Why? Because we decided that it is important to adopt new techniques and technology. And when India said yes to the new technique and technology, this resulted in several innovations, and the country is in such a progressive mode today. The same yes should become a part of each one of us. We need to be a part of learning the new technique and the new technology that is offered in the fraternity of anesthesia. One tool which has completely changed our practice is ultrasound. Ultrasound guided regional anesthesia and ultrasound guided point of care has been the two vital eyes for the emerging anesthesiologists to master. And also the new technology, including the target controlled infusion and total intravenous anesthesia. In 10 years from now, I predict that the workstations and the inhalational agents like sevoflurane and desflurane usage will be very, very minimal, and we will be moving towards infusion pumps and target controlled infusion. So my request for all the young minds here, please embark on the journey to master this innovation of point of care ultrasound, ultrasound guided block, and the target controlled infusion. Believe me, focus on it now, which will make you an absolute professional leader wherever you practice, whether within this country or outside this country. These are the technologies that will make a difference between a mediocre anesthesiologist and an impactful, enriching, powerful anesthesiologist. So I wanted you all to be extremely powerful anesthesiologists, and wanted to quote, it is not the strongest of the species that survive. It is not the most intelligent of the species, but the one most responsive to change. So I wanted all of you to change for the good, and you need to achieve excellence. And excellence is never an accident. Masters make everything look so simple. The most brilliant of the best do their craft with effortless ease and exceptional grace, or at least make it look like that to all of us who's watching them. So I want to be all of you to be mastered in giving spinal and epidural, mastered in intubating, masters in managing the different kinds of airway gadgets, masters in using ultrasound, so that the whole world will, the excellence that you've achieved will highly be rated. I also wanted to share with you, as the National President of Indian Society of Anesthesiologists, we are doing all measures and steps with great support from the past presidents of Indian Society of Anesthesiologists to make it a very enriching academic body. So we have started the College of Indian Society of Anesthesiology, the academic wing of ISA, which has got 6 deans and 6 associate deans. We are in the process of creating guidelines and advocacy for young postgraduates. We have started the ISA Inland Fellowship, and we have actually signed with 25 institutions across India. And the entrance exam will happen in the national conference at Raipur. So I urge all of you to attend the national conference at Raipur. And when you attend the conference, please do participate in the Inland Fellowship exam. And the top 25 of them will be sent across this country to 25 institutions. So you will go and get mentored by some senior anesthesiologist in this nation, and the ISA will pay your to and fro money and also offer you the certificates for undergoing this 1 week training program. And also, we embarked on the journey to decrease the perioperative morbidity and mortality. So we did a survey across this country and found out 6 common case scenarios as the leading cause of perioperative morbidity. And so we have created an ISA module of simulation-based learning, and we have signed an MOU with 40 simulation centers across India. And we are happy to share that we are going to conduct this almost in every state. And thanks to ISA Vishakhapatnam for taking the lead and doing it in the month of May. I'm sure this will be an eye-opener, and probably every 2 months, ISA Vishakhapatnam, being a vibrant branch, can do this so that it reaches all the private practitioners and senior anesthesiologists in this region to come and be a part of this learning. And also, we have embarked on a journey to make sure that every anesthesiologist would harness the leadership skills that are needed. And henceforth, from the Raipur conference, we have leadership summit where we will have some of the tall names in mentoring coming and talking to us on leadership. We have also signed an MOU with several other organizations, including American Society of Anesthesia, European Society of Anesthesia and Intensive Care. And for those who want to register for Raipur, this is the registration details. And I just wanted to, before I embark into the journey of the TKR, I just wanted to share this statement from Dr. Donald Arnold, President of the American Society of Anesthesia. He said, "I am thrilled about the partnership between American Society of Anesthesiology and Indian Society of Anesthesiologists, two of the largest anesthesia societies in the world, and I'm honored to sign the first MOU between our two great societies. We share common challenges, including patient safety, physician wellness, and leadership. Through this partnership, we will enhance the cultural understanding between our societies, and working together, we will further our ability to share knowledge and innovative solutions across international borders, as well as amplify the voice of anesthesiology." I have great pleasure in sharing this with you, and I invite and welcome you to ISA Isakon Raipur, and I'm sure Dr. Praveen Kumar and Praja Madam and Srinivasa Rao will take this message forward to all the anesthesiologists in the city and the state to come in large numbers to witness a conference which will have 17 workshops, more than 25 international faculty, including the president of the World Federation of Society of Anesthesiologists. And quickly, as a secretary of the World Federation of Society of Anesthesiologists, I have great pleasure in sharing that the WFSA works for universal access to safe anesthesia, and the mission is to unite and empower anesthesiologists around the world to improve patient care. As the secretary of the World Federation of Society of Anesthesiologists, I've learned a lot, and I'm very happy to share that India is doing extremely well in terms of anesthesia fraternity. The strategic keywords for WFSA is educate, collaborate, and advocate. And I congratulate ISA Vishakhapatnam for this endeavor of educating postgraduates and members through these webinars. And I request the city and the state branch presidents to take it up very seriously on them to represent India in large numbers in the forthcoming World Congress of Anesthesia, to be held between 15th to 19th of April 2026 in Marrakesh, Morocco. And I would be happy if Andhra comes up with at least 20 people attending this Congress, with 20 abstracts that they will send from the clinical work they do. So as I said, we are a joint replacement center, and in India, the requirements of joint replacement is on the rise because people who live over the sixth decade of life commonly have severe osteoarthritis, which make them a candidate to undergo surgery. Before this era, many people lived with this for several years. You see, this is how the knee joint looks because of a varus and a valgus deformity, and they find it so difficult to walk. But things are changing. So, this patient grew because of a severe deformity. Replacement is just surgery. And see this patient after the surgery. So which life you prefer? The one the life previously was living or this life? Sometimes you're unfortunate. So this is the joint, it looks before surgery, and this is what happens after. But unfortunately, sometimes it happens even when you're young. With rheumatoid arthritis, this patient had rheumatoid arthritis, and she had to get help from such a young age and see her face surgery. So this is absolutely life-changing. And as I said, there are many, many reasons, but commonest is degeneration. Lesser common things are trauma, tumor, congenital deformities, rheumatoid arthritis, ankylosing spondylitis, and conditions like achondroplasia. So this is a patient with, she's a rheumatoid cripple, and you see the way the hip is fused, knee is fused. So she had to undergo total elbow, total shoulder, total hip, and total knee replacements. So now we have, as Dr. Kuchela Babu said, the holistic growth in anesthesia happens when an anesthesiologist does a pre-anesthetic assessment and optimization of the patient, decides about preemptive analgesia and pre-medication, has an excellent intraoperative protocol, and also watches this patient in the immediate postoperative period. I'm happy to share in my institution, which we have 38 operating theaters, and we are close to 90 anesthesiologists. And we have an anesthesiologist in the ward in the day and in the night, completely posted there to look after the perioperative care of these patients. And it has made a huge impact and change in the way the clinical outcomes are. And I wanted to share that everything that you start from basic as a perioperative physician, I urge all the postgraduates that when you do for a pre-anesthetic assessment, bedside mannerisms are very important. And before you touch the patient, make sure that you use a sterilium to clean your hand. And hand hygiene is such an important component in the perioperative care. And please, next time when you touch a patient, before touching the patient and after touching the patient, please use an sterilium antiseptic. And if you do it, you're starting in a new culture of decreasing surgical site infection and hospital-acquired infection in our patients. So one of the most important thing lies the success of good outcome lies in preoperative counseling and optimization. So an excellent pre-anesthetic assessment is extremely crucial, and the patient's attenders have to be taken into account when you are doing the preoperative preparation of this patient. In fact, they're also explained about what we do during the surgery and what to expect after the surgery. And we also make them go and speak to patients who have already completed the surgery and who are in the process of rehabilitation to remove the fear of anesthesia and surgery. And as I said, majority of them are in the geriatric age group. And two things are important for us to realize, that after the age of 40 years, the organ reserves keep decreasing. There is a decrease in every organ reserve by 1% every year that will live after 40 years. So somebody in the 80th year who comes for a total knee replacement, that means 40 years after the 40th year, which means there is a decrease of 40% of their organ reserves, including the heart, the lung, the liver, the kidney. So you are challenged by organs which are only working 50% at the age of 80. So this is the first factor and point that you should note. Next, majority of them after 60 have 1, 2, or 3 comorbidities, and in India, the order of occurrence, diabetes mellitus is the commonest, which is followed by hypertension. Third common thing is ischemic heart disease. Fourth common thing is decreased in hemoglobin level or anemia, and a deranged renal parameter and deranged liver parameters. So it becomes crucial and important for us to look at the HbA1c. And any HbA1c more than 9 shows that there is a possibility of an organ damage, and there is a possibility of an infection that can happen in this patient. So you need to be extremely careful in these patients, and we need to take adequate precautions to make sure that the glycemic status is maintained in the perioperative period. Next is hypertension, and many of them are on diuretics, statins, and antihypertensives, and it is crucial that we need to continue the beta blockers which they are taking. And we also have to take into account that if you're going to do it under neuraxial block, there could be an accelerated hypotension post-spinal. So we need to be on the guard when they are on hypertensives and on antihypertensive medication, especially because they have the hypertensives have a reduced intravascular volume. And so when we give a neuraxial block, when there is a systemic vascular resistance is decreased, there is a sudden decreased in the volume status, and this results in hypotension. So which needs to be kept in mind when we anesthetize this hypertensive patients. And I will come to the method of anesthesia in preventing this hypotension a bit later. So many of them are on cases of coronary artery disease, and many of them are on antiplatelet drugs. The important point I would wanted to share is, in case if they're on antiplatelets, you just have to stop clopidogrel, but you need to continue aspirin. Aspirin has been proved to be very safe, does not increase the blood loss. And for patients who have both coronary artery disease and cerebrovascular disorders, aspirin to be continued 75 milligram once daily and even 150 milligram once daily has not found to produce any side effects. But clopidogrel should be stopped a minimum of 5 days prior to an elective procedure. And in case of ischemic heart disease, it's also important to get an echocardiogram done to see the ejection fraction. And if the EF is less than 40%, it may call for using an intra-arterial line in the perioperative period to closely monitor the blood changes in fluctuations in the blood pressure. And also, whenever the EF is less than 40, you need to be very rationalized in administering fluid, because they may end up with left ventricular dysfunction. Because of that, a significant pulmonary edema. So you need to be immediately, the minute you see IHD, so these things have to be coming into your mind, and you're starting planning for strategies in the intraoperative period. Anemia is very common. Most of the time it is because of nutritional, either because of nutrition or because they take very well, but the absorption from the gut is impaired. And many of them, especially diabetes, producing diabetic nephropathy, hypertensive nephropathy. So when you see these patients in the preoperative room, even if urea creatinine is normal, they're long-standing diabetic, I would wanted you to see the urine routine and plus specifically look for urine albumin. If it is albumin is 1+, that means the nephropathy has started, and you should avoid using non-steroidal anti-inflammatory drugs in this patient. And in the investigation parts, certain things which I want you to, one is serum albumin. Serum albumin is an important indicator of outcome measures. A serum albumin of less than 2 grams per cent shows that the patient is poorly nourished, and his healing may be impaired, and the outcomes may be poor. So this is an indicator for the perioperative outcome, and I wish that all of you should be cognizant of this fact. Next common thing we see in geriatrics is sodium loss and hyponatremia, and a sodium of 130 plus is essential in the intraoperative and the perioperative period to prevent hyponatremia induced cognitive dysfunction of the elderly. And the next important thing I wanted to share is whenever you do a surgical procedure, because of the tissue injury, there is a plethora of pro-inflammatory substances that are released into the circulation, and most important them is interleukin level. So when the decision comes whether to do a unilateral TKR or do both the knee replacements together, it needs to be based upon their age, organ reserve, and comorbidities. And if they are older than 80 years, if they have multiple comorbidities and polypharmacy, I would strongly recommend that you go for one knee at a time and not two knees. The important thing is the tissue injury that you produces phenomenal amount of pro-inflammatory cytokines that are released into the circulation, which can result in inflammatory response syndrome and hypoxia. First organ to be affected is the lung. The next thing that I wanted to share with you is in geriatrics, constipation is very common, and especially if they're in known case of ischemic heart disease, it's important to put them on laxatives because straining at stools is one of the common causes of immediate postoperative acute coronary syndrome and myocardial infarction. So as important as the antihypertensive drugs, as important as the anti-diabetic drugs is also it's very important to put them on laxatives so that they don't strain at stools, because straining at the stool increases their heart rate, increases their blood pressure, increases the myocardial oxygen demand. And because the heart rate increases, because of the tachycardia, the diastolic time becomes less. The time where the coronary gets perfused becomes less, and they go in for a myocardial ischemia. So for all the young postgraduates who are attending the session, I would strongly recommend that please put them on laxatives. So these patients, as I said, have a lot of cognitive dysfunction, and especially if they're alcoholic, you need to start them on thiamine supplements from day one. And many of them have Parkinsonism. And the minute you see a patient with Parkinsonism, you need to be extremely careful and tell the attendants that even one dose should not be skipped. Because if even one dose is skipped, what happens is the rigidity sets in and they're not able to do proper deglutition, and sometimes they aspirate, resulting in aspiration pneumonitis. And if they have aid for a dental aid and hearing aid, I would request all of you to note down in the preoperative visit and make sure that they come with the hearing aid into the operating room so that you can communicate with them. Otherwise, they will not be able to understand anything you say. And all these patients richly benefit from incentive spirometry. If they're smoking and stop smoking, put on a nicotine patch. If they're taking alcohol, put them on thiamine supplementation, 100 milligram hourly to prevent the delirium. So those who are taking long-term steroids, you need to continue steroids because their hypothalamo-pituitary axis is suppressed. And during a stressful situation, they go into profound hypotension. So in your preoperative visit, if you have seen that they are taking steroids for various reasons, including bronchial asthma or any other autoimmune disorders, kindly continue steroids in the intraoperative period and the postoperative period. Many of them also are in a hypothyroid state, and that's why when you give general anesthetic, many times there is a time taken for their recovery. So thyroid status also is very crucial in this age group. And I would wanted to share that all these patients, because of poor activity of daily living, many of them are not ambulating because of the knee pain, and they're also become obese because they're not ambulating well. So many of them develop deep vein thrombosis. So it's important as a measure to rule out a DVT presence by a venous Doppler before we take them for surgical procedure. And many of them who come for TKR, total knee replacement, also like the knee joint, which is degenerated, they also have their spine that is degenerated. And many of them would have undergone a spine surgery and spine fixation. And some of them will have scoliosis because of the degenerative spine. This is extremely crucial for you to examine before procedure, the local examination, because you should not be surprised that you have not seen it. And when you wash and go inside, you will see a huge scar in the back, and you do not know why the scar is there and whether you will be able to perform a spinal epidural. So this is again something which I wanted to emphasize. on appropriate preoperative preparation include the examination of the spine. And similarly, if they have a degenerative scoliosis, it sometimes becomes impossible to give spinal. And so it is important when you do a pre-anesthetic assessment, also look for the spine x-rays. Here, invariably in our hospital, for all those who are undergoing TKR, along with the x-rays that they take for the knee joint, they also take an x-ray of the spine, lateral view, for us to view how much is the degeneration and if there is a scoliosis component. But one practical tip that I wanted to give is, even in the presence of scoliosis, if you're confronted with a case like that, if you think that it usually involves L2, L3, L4, my suggestion is, when you see a scoliotic spine, go to L4, L5 level. They do not participate in the change in the curvature, and you will be extremely successful. So in the presence of a degenerative scoliosis, please go for space L4, L5 space. So this is just to show that they're very degenerative spine. And you see that is the picture is in the lateral view, but you see a big scar there, and many times you will see that it's all fixed and fused. So for younger patients who are coming in for total knee replacement, we can plan for autologous pre-donation. If their hemoglobin is more than 12 grams percent, we can afford to take it up to 10 grams percent. And we employ this in young patients, like for example, with ankylosing spondylitis, rheumatoid arthritis, but who are otherwise fit, who have a good hemoglobin. We take 1 or 2 units based upon the requirement in the preoperative period, and then transfuse them in the postoperative period after the surgery gets over. And we have set a goal and a protocol on how we do these patients. So the night before the surgery, when they get admitted, after proper evaluation and optimization of their comorbidities, when they get admitted, the day prior to the surgery, we give them pregabalin 75 milligram. If the urea creatinine is normal, we put them on non-steroidal anti-inflammatory, 1 gram paracetamol, pantoprazole, 40 milligrams, and a small dose of benzodiazepine for them to get a good sleep. If they are on statins, do continue statins for the night before. This is important because this is called as preemptive analgesia. So this protocol can be set in all the institution on procedure-specific drugs. And since TKR is a musculoskeletal thing and not visceral component, that's why you see a non-steroidal inflammatory, a paracetamol, and pregabalin for the neural component that is involved. But if the same thing is for a laparotomy, the visceral component is involved, and you may have to include a opioid along with the other drugs. So it is important to know how to treat a somatic pain and how to treat a visceral pain. And TKR is a purely somatic pain. And it becomes important that you also, as an anesthesiologist, have to closely watch how the surgical procedure is being done. And that the anesthesia of choice for us in my institution is for total knee replacement is a combined spinal epidural in geriatric population. The reason of using, though the surgical time and the tourniquet time of a total knee replacement surgery will be anywhere between 40 minutes to 50 minutes, and not more than that. But what I prefer and what I wanted to share with you is, in spite of a short duration of surgery, which can actually done with just under a spinal anesthesia, I always prefer and I advocate a spinal epidural anesthesia because I give a very low dose spinal. For example, if the patient is above 80 years of age, I give only 1.2 ml of 0.5% bupivacaine intrathecally. If they're above 90, I've hardly seen any patient coming for replacement. The one which I've done, the senior most or the eldest I've done a total knee replacement is 89-year-old patient who was otherwise very fit, but who was with severe restriction of movement and severe pain. So we went ahead and operated. But in general, majority of them come between the 70 and 80 and 60 to 70. So when they're between 70 to 80, then we give a dose of about 1.5 ml of 0.5% bupivacaine. Between 60 to 70, we go up to 2 ml of intrathecal drug and put an epidural catheter. Why an epidural catheter? Because of the low dose of the spinal that you gave, the two-segment regression and the spinal effect starts wearing off in 45 minutes. So at the 45th minute, we'll start giving the top up 3 ml liquids of 0.5% bupivacaine heavy every 20 minutes after the 45 minutes to continue the surgical anesthesia for this patient. What's the advantage of this? Why this and not spinal? When you give spinal, you end up giving 2.5 to 3 ml of your local anesthetic, 0.5% bupivacaine, which produces significant fall in systemic vascular resistance, resulting in relative hypovolemia, hypotension, needing vasopressors, and sometimes even drugs like atropine for the bradycardia, which you're going to this polypharmacy would result in increased myocardial oxygen demand, and you start giving a lot of IV fluids. And what happens because of this? The IV fluids go into the urinary bladder, and the bladder starts enlarging. Normally, it's a dictum that in a TKR, it's best to avoid bladder catheterization whenever possible, because every time you put a urinary catheter, it produces severe bacteremia, and the vegetations can go to the newly implanted areas. So in our institution, we keep it very guarded. We try to do it minimal. And one of the ways of preventing bladder catheterization is to prevent this hypotension. And preventing hypotension is by using combined spinal epidural, low dose spinal, very less fluid. And also we have made it as a protocol that when you infuse larger amount of fluids, when we nurse them in the HDU, we look at the urinary bladder, and if it crosses 500 ml, immediately under sterile aseptic precautions, we catheterize them. Otherwise, what happens is they develop what is called as postoperative urinary retention of the elderly. It's a new concept, and I want all the PGs to read POUR, the postoperative urinary retention of the elderly, because the detrusor muscle balloons off when it more than 500 ml. And even after that you catheterize, the detrusor muscles have got so stretched for them to get back to their normal level of contraction. It takes 2 to 3 months. During this time, the residual urine is more, and the residual urine results in increased urinary tract infection. So many TKR patients, if you don't follow them, these rigid protocols will end up in urosepsis 2 to 3 months later, and you may not even know that they died because of a urosepsis secondary to what you did in the intraoperative period because you never followed up this patient. These are some important things that I wanted to share with you, that clinical outcomes are not just seeing them coming out of anesthesia and making sure that they're pain-free in the first 6 to 12 hours. It's much more important that they'll have to live. They came for a surgery because they want to live. They want to walk well. And it becomes important that we need to address all these issues. And so, as I said, my choice is a combined spinal epidural anesthesia. And the first, when the skin incision is made, you know whether the dermatome has blocked well. And next, they open up the joint like this. Then this is the next step. And then they do the cuts, and then the cuts have been done, and now the joint is prepared, and now they put the implant, the cement. So it is important for you to know the steps, the cement that is put inside, because each step an anesthesiologist has to be well versed to know whether there could be any complication. Like, for example, putting cement inside, if it is associated at that particular point with hypoxia and hypertension, you know that this is because of the bone cement implantation syndrome. So that's why it's important for you to know stepwise what are the things that can happen in the intraoperative period based upon what the surgical step is. So as I said, the choice mine is combined spinal epidural anesthesia, but there are places where it can be done with spinal anesthesia with a femoral and adductor block. Preemptively, they do it. In some places, there are case reports of doing the whole total knee replacement under lumbar plexus and sciatic. And there are institutions which still do it under general anesthesia plus regional anesthesia. And the blocks that have been given are femoral adductor and LIA technique, which I'll come to it a bit later. So at 0 hours, when you give the drug the day prior to the surgery, at 0 hours when they enter the preoperative room, we start this patient on antifibrinolytic tranexamic acid 1 gram to prevent intraoperative blood loss. We give intravenous paracetamol 1 gram as a preemptive analgesia. We give dexamethasone 8 milligram even in a diabetic patients. This is for two reasons. One, as a component of postoperative nausea vomiting, and also as an anti-inflammatory drug as a component of multimodal analgesia. And also the extended use now is it acts as an adjuvant for the local anesthetic solution in prolonging the duration of the block that you're going to administer. And at 0 hours, you also give antibiotics. The drug of choice for us is prophylaxis is cefuroxime, 1.5 gram IV, followed by which we give 2 doses of 750 milligram and we stop the antibiotic. So they get only 3 doses. It's very important to have this components in our clinical practice because all of us know about the antibiotic stewardship program, which is being done throughout this country to prevent drug resistance. So I wanted and urge all the postgraduates to read more about this concept of antibiotic stewardship. So we also give a low dose of opioid as a component of multimodal analgesia. The drug of choice we use is fentanyl. And antiemetic, the drugs that we use are, apart from dexamethasone, we also use the serotonin antagonist. The drug of choice for me is ramosetron because it works for 24 hours. And in patients whom you think they give previous history of severe postoperative nausea, vomiting, or motion sickness, we had a new drug which has come into the market that is called as amisulpride. So we give them dexamethasone, amisulpride, and ramosetron, and it's such a formidable combination to prevent nausea and vomiting in these patients. So it's also important to look at the tourniquet time because all the structures below the tourniquet are avascular, and when the tourniquet time increases for a large number of times, especially in geriatric patient, when it's more than 90 minutes or 120 minutes, sometimes when they deflate the tourniquet, there is a sudden gush of blood outside, and also the acidotic material that enters into the systemic circulation can produce significant hypotension. So it's vital that if the case is done under tourniquet, the anesthesiologist have to be there preempting a possible hypotension bedside when the tourniquet is getting released. And as I shared with you, it's important that cement, when they put in, we need to be around and keep everything ready to both oxygenate and to give vasopressors. Hypothermia is extremely common, and geriatric patients do not tolerate hypothermia and they go for shivering. And shivering is one important cause of increasing myocardial oxygen demand because when they shiver, the heart rate goes high and the caloric consumptions become more. There is tachycardia. So I think it's a great way to decrease the temperature loss by using the body warmers, and also that what we call it as the thermo drapes and a bear hugger. And fluids also can be warmed online if facilities are available. Temperature conservation is very important component of intraoperative care. So this is the bear hugger and this is the online IV fluid warming agent. And intraoperatively, as I said, we need to closely monitor the hemodynamics. And I wanted to share with you that the dictum that I teach is to keep the mean arterial pressure equal to the age of the patient. So if it's 80 years of age, try to keep the mean arterial pressure at 80. If they're about 75, keep the map at 75. If they're 70 years, keep the map at 70. This is an allowance that you give for the arteriolar constriction that happens because of arteriosclerosis. So this is a simple dictum that I wanted to share with you. And sometimes they are extremely anxious, so you need to give a conscious sedation. Drug of choice is fentanyl and midazolam. But in patients who are very uncomfortable and have a reasonably good heart rate of more than 80, dexmedetomidine seems to be a nice drug for conscious sedation in this patient. And deep vein thrombosis is a common entity in total knee replacement. So we put these patients on mechanoprophylaxis, the pneumatic compression device, and also we start them on chemoprophylaxis. If they are morbidly obese, then you go for low molecular weight heparin. Otherwise, we put all these patients on aspirin 75 milligram for almost 1 month. So a lot of techniques have come in for postoperative pain relief. And one of the important things is in total knee replacement, why many patients don't come for surgery is because of the fear of unacceptable pain levels after knee arthroplasty. So it happens, the pain is because of the inflammation, the microfractures that we produce, the tendinitis and nerve irritation as a consequence of the surgery. And the pain happens because of it's a nociceptive pain, inflammatory pain, and neuropathic pain. So there are a lot of articles, very nice articles, which has come in to describe the multimodal pain management technique in hip surgery. So the combination that we use is paracetamol 1 gram 6th hourly, 4 grams per day. Non-steroidal anti-inflammatory drug of choice is ketorolac for me, 30 milligram IV 8th hourly, a maximum of 90 milligram if the renal parameters are normal. And in severe deformities, it's good to give pregabalin 75 milligram OD, but a note of caution in Indian geriatric population, some of them with pregabalin become so groggy, so drowsy that we are not able to ambulate them. So if they become very sedated because of pregabalin, please stop them. But maybe just one dose preemptively, but otherwise not to continue in the post-op. And dexamethasone, as I said, is a component of multimodal. The first dose is before the skin incision, and you can give one more dose after 8 hours. And so we have paracetamol, we have non-steroidal anti-inflammatory, we have dexamethasone, plus or minus pregabalin. If we do that, then the opioid requirements becomes less. And now we have moved on into one of the most important component is incorporating regional analgesia into these patients. And primarily the knee is supplied by femoral, obturator, and sciatic nerve branches. But we have moved further down from the main nerves to the three plexus which supply the knee joint: the peripatellar plexus, the subsartorial plexus, and the popliteal plexus. So we have envisioned this, and we have given a new block which the Ganga Hospital department published it in the literature. It's called the dual subsartorial plexus block. I wanted all the postgraduates to do a Google search of dual subsartorial plexus block, where we give two injections, one in the subsartorial region and one in the adductor canal region. So there are, as I said, there are several methods: local infiltration analgesia, adductor canal block, either with a catheter or a single shot block, femoral block still being used in many centers, sciatic block still used in many centers, lumbar plexus is never being done now, and epidural infusion to be continued in the postoperative period for 48 hours. So right from epidural, it went to peripheral and it went to local wound infiltration. So from the center to periphery. So centrally, you give subarachnoid block, epidural, combined spinal epidural, where you put certain adjuvants like opioids. For example, many centers use, along with bupivacaine, they use intrathecal morphine, intrathecal buprenorphine, intrathecal fentanyl to prolong the duration of analgesia, because these are all off-label use. But there are several centers using specially morphine, which has got prolonged duration of analgesia. And the next one is the lumbar plexus and sacral plexus, not being done now. Next is the femoral nerve obturator and sciatic nerve block, not done now because it produces motor weakness and we cannot ambulate the patient on the same day. Most of the total knee replacement surgeons wanted to ambulate the patient on the same day. So it becomes important to go for a block which is motor sparing but also produces good sensory analgesia. That came in DSP block, the adductor canal block and the dual subsartorial plexus block. So now I would urge all of you to learn this technique of adductor canal block for total knee replacement as a component of multimodal analgesia in the postoperative period. The other thing is called the local infiltration analgesia, the IPAC. So, so this is how we give the subsartorial plexus block, and the nerve to vastus medialis is blocked, and this is the subsartorial plexus. So I would possibly show the sonoanatomy of this. So what we need to do is, so this is the femoral artery, the femoral vein, and the femoral nerve. And what we actually block is as you scan these structures down, I think possibly I will share our dual subsartorial plexus video with Dr. Praveen Kumar to be circulated, and also the article that we published to be circulated among its members and all the attendees of today to see how to administer a dual subsartorial plexus block. So the one what you see here is the sartorius muscle, and this is the artery, and the subsartorial plexus below the sartorius muscle you administer the block. So I will share with you those videos, and many times it is asked whether you can knee joint replacement is usually bilateral. The surgical team may discuss with you about operating it on both the sides together, and good planning is needed. If it is young patient, yes. If they don't have comorbidities, yes. But otherwise, it has to be the protocol that we follow is we do one knee today and we give a gap of 3 to 4 days and do the opposite knee later. And the advantages that we have found in doing it in a spaced interval is the ability of the patient to not to receive any blood transfusion. When you do bilateral knee in the same sitting, the chances of blood transfusion becomes high, number one. Number two, their intensity of pain is very high because they can either move left side or right side, and they find it very difficult to ambulate. And also we have found that the cement load that is placed when you do bilateral TKR can result in hypoxemia and needing oxygen supplementation. So my suggestion would be that except if the patient is less than 60 years with no comorbidities and they're willing to go for a bilateral total knee, my choice would be to go for one knee at a time, give a gap of 3 to 4 days, and then do the opposite knee. So in a nutshell, I have kind of presented to you the preoperative assessment and optimization, the challenges that you face in the geriatric patient, the mode of anesthesia that I would prefer, that we have learned over years, which would be the best way to conduct this, where you give low dose spinal, less IV fluids, maintain the mean arterial pressure, and at the same time, make sure that they are pain-free with multimodal analgesia. Take care of small things like hypothermia, postoperative nausea, vomiting. So it's a holistic approach where you are going to take into account every single point that would result in a bad outcome or a morbidity. And I take this opportunity to immensely thank the ISA Vishakhapatnam branch for giving me an opportunity to share it on a topic which is very close to my heart and which we have been doing for several years now, trying to learn several intricacies that are involved in the perioperative care of this patient. My request for every anesthesiologist who is attending this this webinar, this web session is please see yourself the preoperative assessment of the patient, decide the strategy based on the symptoms and signs you see, and decide an intraoperative plan, and make sure that you visit this patient in the postoperative period to make sure that they are pain-free. And believe me, if we embark on a journey like this, every single patient will be ever thankful to us for the wonderful comfort that we gave. And because of that, they are leading a new life because they are able to walk the way they want and they become independent. Let us be a part of a journey where we excel in everything that we do, right from starting an IV access to giving an anesthesia for a total knee replacement for a old patient with multiple comorbidities. Thank you so much for this great opportunity. Thank you, sirs.
Thank you, Dr. Balavenkata sir, for your well organized TKR, how to do in a complicated case and other things. Now I request my co-moderators, Dr. Kameswara and Sursati Srinivasrao, take forward the questions and answers and any discussion for. Thank you, sir.
Excellent, sir. Dr. Balavenkata, sir. You have covered very well from preoperative preparation, the stabilization to the entire postoperative pain relief. Every part of it you have clearly mentioned I think there may not be much doubts for the audience. You have cleared everything in every aspect, and you are doing a great job there. And I wish to mention here to all the delegates that you are conducting GARG conference every year in an excellent way, an international conference with very good lectures and very good workshops, which are very informative to all the postgraduates and practicing anesthesiologists. And I request the delegates to best utilize the GARG conference, which is conducted every year at Ganga Hospital by Dr. Balavenkata. Any
Thank you
questions
so much,
from?
sir. Thank
Good
you so
evening.
much, sir. And I think
Good evening, sir.
since its
Sir.
inception, both Dr. Kameshwar Rao and Dr. Kuchela Babu have been a part of Ganga Anesthesia refresher course, and they are a source of strength. The minute I see them, I feel very happy. Yes, our seniors are there with us. And this conference, as Sir said, next one is on July 16th to 19th, 2026. We just finished this conference this year. So I look forward to having more of young postgraduates participating in the next Ganga Anesthesia refresher course. Thank you, Kameshwar Rao sir and Kuchela Babu sir, for being with us every GARC. Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, sir. Balavenkata, sir. Today also we learned some new things, especially nobody thinking of urosepsis, especially orthopedic cases. That is a new thing now. All the postgrad has to be taken care of. Why you are giving a low dose of the spinal drug? That is also new for us because regular practices everybody will give the 3 cc or 3 cc or 4 cc and they will continue the things. But as you rightly mentioned, we are not doing a continuous follow for the patients, and sometimes we may miss the urosepsis, and it's a new thing to me also. For me, I learned through this lecture, and remaining topics and preoperative and intraoperative post-op. They're excellent, sir. Because as a good academician of ISA National, it's very immense pleasure for ISAP also to invite you for this ISA webinars to the ISA, sir. We are coming forward to you to work along with you, sir. I request any questions in the clarinet because now they are not displaying here.
Sir, I just checked the portal, and sir, we did not have received any questions.
Sir, when you are giving morphine intrathecal, is it essential to keep the indwelling intraurinary catheter because of the possibility of urinary retention?
Yeah,
with
true, sir.
morphine?
Actually, in my institution, we don't use intrathecal morphine, sir, because there are few cases of protracted itching that happens because of intrathecal morphine, and occasionally they've seen respiratory depression happening because of morphine. So because we do large volumes and we don't want to encounter this problem, we have stopped. I mean, in fact, we have never used morphine as an tool, sir. And now with more of regional anesthesia, we have gone for dual subsartorial plexus block as the best method of multimodal analgesia with least complications, sir.
Okay. Because I have experience with epidural steroid. Initially, I used to mix up with morphine also. But I've seen pruritus, as you said, is a common complication or a common side effect I have noticed with the patients. Not much of urinary retention, but this pruritus is a problem with morphine.
Yes, sir.
Sir, I heard somewhere this cryo caps they will apply for the post-operative. Have you any experience that, sir?
No, sir. No. I've actually spoken exactly what we do. Every bit what we do, right from xeno over medication to what we do post-op, the protocol that we follow, I've mentioned, and we refined all this over a period of time. We do silent audit. We ask our clinical pharmacist to do an audit of all our TKRs. Every year once we do it, and we try to see are we doing justice to our patients or we should modify our practice. So a lot of feedbacks comes from the silent audit that we do. And that's how slowly we have embarked on this particular protocol over several years.
Sir, regarding this preoperative gabapentinoids for the preemptive analgesia, do you continue the post-operative also, sir?
No, sir. That's what I said. That's why I said in Indian population, it produces severe drowsiness. And they don't take part in ambulation, and you're also producing a possibility of them falling down. when they are ambulated. That's why, sir, actually, we have almost, even in the pre-op period, except for significant deformity, we have stopped that particular drug. But paracetamol, non-steroidal anti-inflammatory, yes, we give it for all the patients.
So what anticoagulant you are continuing in the tablet form? Rivaroxaban you are giving for 2-3 weeks, or
We,
after this?
as a protocol, there was a big study done in 800 cases in our institution, and we found aspirin 75 milligram once daily for 30 days was sufficient enough for the population to prevent a deep vein thrombosis. And it became easy because you're not worried about any form of hemorrhage happening anywhere. So now our protocol has been 75 milligram aspirin for 30 days. Except for those who are morbidly obese and bilateral TKRs, where we immobilize for a long time, then we use enoxaparin for the first 5 days in the post-surgical period, and again go back to aspirin, sir.
You can go back to aspirin.
No oral anticoagulant, sir.
Right now, no, sir. No oral anticoagulants in our TKR.
I have one more question about the postoperative regional blocks. What is the maximum duration? Is it the first 1 day, 24 hours, 48 hours, or 72 hours? Maximum technique you will do.
Sir, when we
You
add
put a continuous catheter, adductor canal block, when you will
yeah.
take up and when you switch to the oral.
Sir, actually now, after we started using dexamethasone as an adjuvant to our dual subsartorial plexus block, we have stopped using catheters, sir. So dexamethasone average duration of decrease in VAS score, pain score is between 18 to 22 hours, 4 milligram and 8 milligram when we add. After we started using this, we have stopped using the catheters, but there are several centers in this world who use adductor canal catheters, and they keep on infusing low dose of 0.125% bupivacaine or 0.15 to 0.2% ropivacaine for pain relief. And at the same time, if it's an adductor canal block, the motor component is less, so they can still ambulate the patient. But generally, everything is for 48 hours, sir. After that, the intensity comes down and the multimodal analgesia takes over.
In the ward, if a patient is sent to the room, there is no more regional anesthesia. It is only the IV or oral, or it may be fentanyl patch.
Sir, actually,
what about to take a message from the fentanyl patch? There's some center they're using before 12 hours before the surgery, they're putting a fentanyl patch. The maximum concentration can reach just night before, and they're continuing for 3 days.
Sir, actually, fentanyl patch, according to me, opioids is okay, sir, but this is a skeletal pain, so it's more of paracetamol and non-steroidal. There is no visceral components, so we can achieve our target more with the paracetamol, but most of them don't give 4 gram per day. They don't give 90 milligram ketorolac. That's why there is breakthrough pain. So I would recommend using up to 4 grams per day and ketorolac 90 milligram per day, at least for the first 48 hours, and then to step down.
How is the pain score in the post-operative after 48 hours? What is the pain score? Most of your patients,
sir, we aim at a score of less than 3, sir.
What is the rescue analgesia you give? Now the paracetamol with the catalog. What is the rescue?
Rescue analgesia is if the pain scores are more than 5, then we go for a repeat block, sir. We go for a repeat block with an adjuvant. But if it is less than 5, then we will give a step-up dose of 1 more gram of paracetamol. And now we have got ibuprofen, IV ibuprofen, which is also a profound analgesic, 800 milligram stat. So this could be also a rescue analgesic. At the same time, you put on pantoprazole to prevent gastritis. So,
one is the discharge. What is your normal criteria for the post-operative? How many?
4th day they get discharged, sir. In our institution, the 4th day they get discharged.
So, what is your normal audit of the just before discharge? What is the pain score of these patients?
Sir, normally at the 4th day, when they are quite sitting, there is no pain. But when they
Okay.
ambulate, there is a level of discomfort that is present. And that is actually, that's why when you discharge them with paracetamol. We don't put non-steroidal for a long time, sir, or discharge non-steroidal for 3 more days. So a maximum of 1 week of non-steroidal. But paracetamol, we continue it for almost, even if they want 2 to 3 weeks. So there we decrease the dose to dolo 650 milligram 3 times a day until they have discomfort. And we tell them SOS they can take the tablet. It happens mainly when they ambulate themselves.
Okay, sir. Thank you. Thank you very much, sir.
Good evening, Dr. Balavenkata, sir. This is Dr. Subramanian from Anantapur, sir.
Yeah, good evening, sir.
Really an excellent presentation, sir. And you have touched even the minute details right from pre-operative, intraoperative, and also post-operative, which would have been very useful for postgraduates and also practicing anesthesiologists. So in some centers, they before closure, after the replacement, they instill some cocktail containing of local anesthetics.
Yeah, exactly, that can be done. That's why I said it's called LIA, local infiltration analgesia. But the point is, sir, it's better than not doing anything. But usually by 8 hours after infiltration, it wears off, sir. So that is the biggest challenge. When you do the surgery in the morning, when all the doctors are there, patient is fine. When every doctor has left at night, the patient is having severe pain. That's the problem with if you use only LIA technique. But LIA with multimodal with a nerve block, night also is peaceful, sir.
Okay. Thank you, sir.
Sir, thank you so much, sir. It was
Thank
such
you,
a
sir.
pleasure. It's a great opportunity to meet several leaders of ISA through this webinar and also to participate in the session of ISA Vishakhapatnam branch. Looking forward to meeting all of you in person in the South Zone Conference in Vishakhapatnam in the first week of July. Actually, I have one more WFSA session coming up now. So I will take your permission to attend that session, sir.
Thank you very much, sir.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you, sir. Thank you so much, sir.
Thank you very much, Balavenkat, sir.
Thank you.
Thank you, madam. Thank you so much, madam.
Vote
It
of
was such
thanks.
a
Can you,
pleasure. Yeah,
Yes,
thanks
sir.
for
Praveen, vote
I-
of thanks, you can go ahead.
Yes, sir. As we
Sir,
conclude this
before that, sir,
enriching
one
academic-
question in the posted in the clarinet. Dr. Balakrishna Prasad, he asked if you want to use dexmedetomidine intrathecal bupropion.
No, sir. Sir, I've
Not-
never used and I don't want to promote it, sir.
Okay.
Okay. So, as we conclude this enriching academic session, it's my privilege to propose the vote of thanks on behalf of ISA Vishakhapatnam City Branch. First and foremost, our heartfelt gratitude to Dr. J. Balavenkat Subramanian sir for delivering an insightful and engaging talk. Your clarity of thought, clinical wisdom, and passion for teaching have truly inspired us, sir. A special thanks to our esteemed moderators for guiding the session with their trademark grace and wisdom. We are thankful to all the participants who joined this evening and made this session vibrant. Lastly, my sincere appreciation to the technical team of ClearNet for ensuring seamless conduct of today's webinar. So let us continue to learn, grow, and contribute together to the field of anesthesiology. Thank you, one and all.
Thank you so much, sir. Thank you.
Thank you, sir.
Thank you.
Thank you very
you,
much.
sir.
Thank you, sir.
Thank you. Good
Thank
night.
you so much. And Clarnit is really glad to have all these brilliant people together in this session today. Thank you so much for extending us the opportunity to host the session. And I hope you all had a seamless experience. So, with everyone's permission, I'm closing the session today and looking forward to hosting you again. Thank you so much.